and will be recorded. For the benefit of everyone, the conference line has been muted for all participants. We will open up for questions in the last 10 minutes where you can submit your questions via the questions pane on your control panel. Please note, if you have any questions during the webinar, you can submit them and they'll be answered at the end. Dr. Tuomo Nieminen is a Professor of Internal Medicine at the University of Helsinki and Chief Physician of Internal Medicine at the Hospital District of South Karelia and Helsinki University Centre Hospital. Dr. Nieminen attained his Doctor of Medicine at the University of Tampa in 2005 and became a certified clinical investigator within a year. By 2006, he was Assistant Professor, Senior Lecturer, Clinical Pharmacology, University of Tampere, and began his residency for internal medicine training. He has been an editorial board member of 3 journals and held memberships in various cardiac scientific societies. He also served as the chairman of the board in 2 companies operating in the nursing care business. Thank you so much for your time today, Dr. Nieminen, and I now hand the webinar over to you.
Yeah, thank you very much, and welcome everyone to this webinar. So last time we talked about sudden cardiac death, about clinical importance, and about the mechanisms how sudden cardiac death occurs and how it happens. So this time we will talk about how to predict whether a person is prone to suffer from sudden cardiac death and how possibly to prevent sudden cardiac death in a person who is prone to get such an event. So basically we will talk about non-invasive predictors of the risk for SCD, and mostly those will be taken out of clinical exercise tests. There are also some other tests, for example, out of Holter, out of regular ECG, but quite a few of the non-invasive tests are taken from exercise tests, and also ejection fraction. That's actually the main non-invasive marker. And ejection fraction, it's typically taken out of echocardiography. And then we will go on to talk about the prevention of sudden cardiac death, about the possibility with the drugs, and then about ICDs, implantable cardioverter defibrillators. Just as a reminder of the clinical importance, so there are more people dying from sudden cardiac death than from AIDS, breast cancer, and lung cancer combined. So we are really talking about very remarkable trouble in clinical practice. And now we are talking about strict risk stratifiers. So basically, if we are thinking here, population, this is age which goes along to the right, and population who are healthy, so they have a quite low risk. And so if we are having some risk markers, possibly several risk stratifiers, we might be able to lift the knowledge of the risk for some of the patients, and so that we will have higher risk for them, and we can concentrate with our efforts with these patients here. Basically, an ideal stratifier, it would be such that we can find out the patients who have an elevated risk within certain amount of time, for example, within 5 years or within 2 years. It's not very important to know whether a person is prone to suffer sudden cardiac death in, for example, 20 years. This is a list of quite long list, by the way, about possible markers for sudden cardiac death. So I'll take here just a couple of them. So left ventricle ejection fraction, this is a very remarkable one, and we will talk about this one also. Then there are, for example, New York Heart Association functional class, which means that if there's a heart failure in a patient, but he doesn't or she doesn't have any symptoms, so he can walk, for example, several miles or kilometers, then the person has a NIHA class 1. But on the other hand, if the class is 4, then such a person suffers from symptoms even when at rest. And the 2 and 3 are in between. Then there are electrophysiological markers, and some of these can be taken from a Holter recording, and some of them, for example, T-wave alternance, it can also be taken from an exercise test. But then there are, for example, heart rate recovery, which is taken out of exercise test, and several other markers. For example, these here can be taken from magnetic resonance imaging of heart. This is also just a reminder of the last time that there are patients who are at very high risk of sudden cardiac death, but there are so few of these patients that the total number of these suffering sudden cardiac death is actually quite low. So the number of sudden cardiac deaths is much higher in patients who are actually quite healthy. They just have some risk factors or very few risk factors. They are so very small risk individually, but because there are so many of those people, they form a very large group in all. So shortly about diagnosis versus prognosis. It's clear that the diagnosis, for example, out of exercise test, it's for mostly diagnosing coronary heart disease and certain arrhythmias also. But then these days we can use the device much more to record what is the prognosis of the patient, so what kind of foretell the course of a disease. And basically heart exercise test, it has been used very much as a diagnostic tool to find out coronary heart disease or coronary artery disease, which are same, and to get level of ischemia what occurs within the exercise test. But the most newest literature, it's mostly concentrating on the prognostic abilities of the test, and then some of the new guidelines, for example, the American ones, they say that there is too heavy focus on diagnostics, and we should talk about more prognostic features of the exercise test. So basically, abnormal responses in an exercise test, so they may indicate elevated risk of coronary events such as myocardial infarction and also death, also sudden cardiac death. And this is possible even though the patient would not have ischemia, visible ischemia during the test. And there are many prognostic factors or indices, and they are typically related to the general fitness, so how good, how well can the person do the exercise test. And also there are markers about autonomic nervous system. These can be taken, these nervous system markers, also from the recovery phase. Exercise capacity, it's actually it's very simple thing, but it's a very powerful prognostic markers. Typically, we handle exercise capacity as metabolic equivalence, which means that there's some level of energy consumption when a person is resting, and now when he or she is exercising, there's some multiple of the resting energy or oxygen consumption, and this is called MET. For example, if a person walks, typically it might be 4 or 5 METs. And then also there are some other exercise capacity markers, but MET that's the most might be most universal. And this MET, it has been studied in quite wide range of people and patients, and it seems to be better than, for example, a myocardial perfusion imaging or SPECT, and also it's better than coronary angiographic findings. It might even be the best marker from the exercise test. Here I have the quintiles of exercise test and relative risk of deaths, and these are normal subjects, the black ones, and these are the ones with cardiovascular disease, but they are very similar parts in all of these. So if the MET is less than 6 or 5, something like this, the risk is very high, and it goes down when MET values increase. So typically cutoff point for a treadmill test, it's 8, and for bicycle ergometer we typically use 6. I'm not quite certain whether you use treadmill or bicycle ergometer in your countries. Also, we can take a look at it a little bit from a different perspective here. If there's a person, for example, 55-year-old, and he or she gets 5 METs, then if he is man, then that's about 60% of the average value for that old man, and similarly for women, it would be 70%. And if we get the value less than 85%, then it's considerable factor of risk. Heart rate, it's a very remarkable risk factors. It speaks very much about the sympathetic and parasympathetic activity during the exercise test, because when we start exercising, the parasympathetic activity fades in the very beginning, and after a minute or so, even the sympathetic activity changes. It of course increases, and even adrenal medulla releases norepinephrine and epinephrine into the bloodstream, and heart rate increases. There's a concept of chronotropic incompetence, which basically means that heart rate does not rise as it should rise. There are many different ways how to define it. Some people have in some studies they have used just maximal heart rate, or what is the increase, kind of the delta in heart rate, and then maximal heart rate. It's of course dependent on age, so typically it's calculated with one of these equations here, and if the maximal heart rate is below 85%, then it's a clear risk marker. Here this is a little bit more elaborated marker of chronotropic incompetence, but this is probably the best way to get it. So, because if we are taking only maximal heart rate or increase in heart rate, then at that case we don't pay any attention to what is the resting heart rate. But now, if we calculate what is the expected heart rate for this patient of this certain age, and then the person actually has a heart rate maximally, this one here in the exercise test, then we just divide this A by the B and we get the chronotropic index. It's kind of the proportion of heart rate reserved used. And if it's a treadmill, the person should get more than 80%, and in bicycle they are physiologically a little bit different. And for example, treadmill uses more, even larger muscles, and it's a little bit different, the percentage here. So if there's a person with beta blockers which hinders increase in heart rate, then typically this chronotropic index is a little bit lower. Then we will talk about heart rate recovery, which means the recovery after the exercise. It could be taken at any minute after the exercise. Typically, it's taken 1 minute post-exercise. So basically, heart rate increases to the peak of the exercise, and then it starts declining. And this declining is mostly within the first minute because of vehicle activation. So parasympathetic activity starts again, and heart rate goes down. So if there's an athlete, then of course typically they have higher heart rate. These are logarithmic heart rates, so we don't need to pay attention to these numbers, actual numbers here. So athlete, the heart rate is higher than in normal people, but then it goes down also very quickly. And if there's a person with heart failure, they have lowest heart rate maximally, but it goes low, even lower than in people, normal people. And so now whether the exercise test is terminated with the cool down period or without a cool down period, then of course it gets different heart rate recoveries. If there's no cool down period but the person is taken to rest right away, then heart rate recovery, it should be at least 18, but if there's a cool down period, the recovery might be only 12. And here we can see that if the heart rate recovery, it's kind of a continual function in the way that if it's less than 20, the risk of death goes up actually quite quickly, and it's also true for sudden cardiac death. Then about ventricular extrasystoles. So, and this is first during the exercise test. There are several studies, most of them have found that extrasystoles during the exercise test are of prognostic significance. And basically, if there are more than 7 extrasystoles a minute, then that is a marker or harbinger or sudden cardiac death and death generally. And if there are couplets or there are by Gemini, there are some ventricular tachycardia, they are here clearly marker of elevated risk. But this is one very large study, about 30,000 patients, and it shows that the ventricular extrasystole, they might be prognostic factor also during the recovery phase. And why is this? Why does it happen? Why is the risk elevated in these patients? So it's a hypothesis that in patients with higher amount of ventricular arrhythmias during the recovery phase, they have a slower reactivation of parasympathetic activity, and that's why they have many extrasystoles. And if the vagal activation is stronger, then it diminishes these arrhythmias. Then there are also many other parameters taken out of the exercise test. Next time we will talk about the T-wave alternance, which is an electrophysiological marker, and there are also blood pressure during and after exercise. But one thing is that we have actually quite a few markers already, and we should have some strategy how to cope, how to handle the multitude of risk indicators. And for example, there are 2 cases here. There's this blue line, it's how heart rate progressed during an exercise test, and this is a man, 61 years old. He had a very nice MET, so the exercise capacity is high. Heart rate, it went up and it went down nicely. Heart rate recovery is 24, and also what is not visible here, he had a very low T-wave alternance, and he had a very good prognosis. Then there's a little bit older man with low MET and low heart rate recovery and elevated T-wave alternance, and he died after 2 years post-exercise. So I believe that the exercise test equipment or the software, it could calculate all the possible values and then categorize all the risk based on the validated markers. This would be quite similar to what it does for ECG device, and of course some of the exercise test equipment, they do such a thing here. But at the end of the day, it's also always the physician who needs to really see what is the risk. This is also true for the ECG automatic diagnosis. So the physician never takes those at face value, but always he or she needs to take a look at the ECG and make own diagnosis. Then I will have a couple of slides about ventricular extrasystoles, which are taken at rest. And this is a very common type of extrasystole, most common type. It starts from right ventricle, from the upper part, from the outflow tract, RVOT, and ECG. We can see that it's it goes down regarding the frontal axis, so it goes from up to the down very strongly, and also this QRS complex, it looks somewhat like left bundle branch block. So this configuration means that it must come from the right ventricle and from the upper part. And this is typically a benign extrasystole. There are also other ways to classify extrasystoles, but typically so that they get more and more complex. But if there's a otherwise healthy heart, so it is not dangerous to have several types of extrasystoles. But what is important, if there's a patient who has ventricular extrasystoles, then we need to find out whether there's some structural heart disease below. Mostly R on T phenomenon is taken as an ominous sign, and for example here it means that there's a QRS complex and T wave, and if an extrasystole occurs like here on the recovery phase on the T wave, then the person gets ventricular tachycardia and ventricular fibrillation. But if this happens, if patient is vulnerable to get an VF when R on T, R wave on T wave happens, then there must be some disease in the heart already. So we will go on to the prevention of sudden cardiac death. First, very shortly about the drugs. There are many drugs which are for different heart diseases, for example, ACE inhibitors and so on. And naturally, because they improve the heart disease, they also decrease sudden cardiac death. But this is kind of upstream type of thing. So those drugs, they don't have any direct effect of the electrophysiology, but they just improve heart disease, which is of course important. But if we are talking about anti-arrhythmic drugs themselves, then beta blockers are effective or efficient in preventing sudden cardiac death. But very importantly, other anti-arrhythmic drugs do not prevent sudden cardiac death. They may well decrease the number of ventricular extrasystoles, but at the same time, they have some adverse effects. For example, they changed features of ion channels, and that is also pro-arrhythmic in nature. It may hinder some type of extrasystoles, but also it doesn't hinder ventricular fibrillation, but it may actually even induce ventricular fibrillation. So this is a very famous study about amiodarone, which is mostly the most important anti-arrhythmic drug. So most efficient one. There were patients who had a heart failure, left ventricle ejection fraction, it was less than 35%, and New York Heart Association class was 2 or 3. This 3 means basically that the person, if he walks very short distances, like 100 meters, there already is shortness of breath or some other symptoms. So these patients were even receiving placebo or amiodarone, but it didn't have any effect on sudden cardiac death or mortality rate. But then if the person had an ICD, they had clearly better prognosis. So we will go forward to ICDs, implantable cardioverter defibrillators. And now if we are talking about pacemakers, there are many different abbreviations and concepts. First, all the ICDs, they are also at the same time pacers for bradycardia, and they might have dual chamber capabilities that they can pace right atrium and right ventricle, or they might have a lead only to right ventricle. Typically, they don't have, well, ICDs, they can never be only atrial pacers. And also an ICD at the same time, it can also be CRT, which is cardiac resynchronization therapy pacemaker, which is also called biventricular pacemaker. But we are here talking about only about the ICD. The history of ICD, it's very interesting. It started by Michel Mirovsky in 1969 already. And the first patient received an ICD 1980, but it was only in the 90s when it really started in very large numbers. And the basic rationale for an ICD is to find out whether a person has an lethal arrhythmia and then to stop the arrhythmia. A question is when a patient should get an ICD, and we have a very fundamental question here. We should know whether a person is prone to get a ventricular tachycardia or fibrillation. And if we are talking about ventricular tachycardia, it needs to be hemodynamically challenging, so that the patient suffers dizziness or syncope. And if there's a ventricular fibrillation risk, then of course a patient should get an ICD. And if the person has already had ventricular fibrillation or possibly VT, then it's self-evident that the patient should get, in most cases, should get ventricular fibrillation, ICD. But then, this is called secondary prevention. But now there's a question of primary prevention. There are people who hasn't have any VTs or VFs thus far, but they are known to be at an increased risk. So this is primary prevention, and worldwide, even more than 80% of the ICDs are implanted based on this indication. Before an ICD is implanted, we need to think about the patient, of the overall aspects of these other diseases, comorbidities. For example, what is the prognosis of the patient regardless of the heart disease? What is the sufficient quality of life? And also studies which have been done for ICDs, they are typically for patients which are a little bit younger and a little bit more healthier than patients in the real life. So this also makes it a little bit more complicated to really define who should get an ICD. Also, price might be issue because these are not very cheap systems. All right, regarding the implantation, it happens in a very similar way to that of regular pacemaker, even though the ventricle lead which goes here to the right ventricle, it's a different because it has these shock coils. Also considerations whether patients should receive also biventricular pacer, that must of course be done this discussion before the implantation. And then the question about programming ICD, there are hundreds of different or maybe even more things which we can program here, and we need to think about the patient and also the studies which have been done. What is the heart disease? It has some importance here regarding the programming, and for example whether bradycardia pacing is important. And then there's a concept of anti-tachycardia pacing, which means that if there's a ventricular tachycardia, then this might be terminated just by pacing very quickly, like 200 times a minute, for a very short period, a few seconds, and that might quit the tachycardia without giving any shocks, real shocks to the heart. I have an example here. This is taken from ECG, from surface as regular ones, and there's a person with a dilated cardiomyopathy. Then he got a ventricular tachycardia. Here we see that the pacing, he had an ICD, and the pacer tried to quit this ventricular tachycardia with anti-tachycardia pacing, but it didn't work out. Actually, the tachycardia moved to a little bit different one, but continued again, and then a person got an electric shock from an ICD, and thereafter, right thereafter, ventricular tachycardia was terminated, and he returned to the paced rhythm. This is what it looks like from the ICD. We might not go into the details here. The same thing. It's also possible that the device gives too many shocks, this ICD device, and there are concept of inappropriate shock, which means that the person receives an ICD shock even though there are no such an arrhythmia ongoing. And algorithms, they get better year by year, and also if the person also has atrial lead, it makes it much easier to recognize what is the rhythm, because then the device can compare atrial rhythm and ventricular rhythm. For example, if there's very quick atrial fibrillation, it might be very difficult to know that it's just AF based on the lead which is in the ventricle. All right, and then there are necessary shocks, so that the shock is received for a tachycardia, which in itself might require a shock, but the tachycardia would terminate by itself. So that's why the shocks, they are not typically not given right away. The charging time is about 10 seconds, but typically the device waits a little bit longer so that it will see whether the tachycardia terminates by itself. Naturally, if there's a ventricular fibrillation, it will not go off just by itself, but a shock is needed there. And if a person gets too many shocks, it's clear that it's very inconvenient, has psychological effects, quality of life might decrease very much, and even the prognosis of the patient may go down with these extra shocks. And this is a graph about what is the heart rate when a person gets inappropriate shocks. And as you can see here, they mostly happen when the heart rate is less than 200. And this is one reason why typically shocks, they are not programmed to occur at very low heart rates. So this is a very short summary about ICD indications. So which patients should get an ICD, and now we are talking about patients who have not had an ventricular fibrillation before. So this is for primary prevention. So basically, it's recommended to reduce the risk of sudden cardiac death if they have a symptomatic heart failure, so that they have a New York Heart Association class 2 or 3. If it's class 4, which means that there's a resting symptoms, then it's considered that the patient is already at such a poor condition that no ICD can really be helpful anymore. And ejection fraction of the left ventricle, it must be a maximum of 35%, and with this patient should be on optimal medical therapy. And these patients, they should receive an ICD, regardless of whether it's for coronary heart disease, this heart failure, or whether it's for some other reason such as dilated cardiomyopathy. So just a couple of slides about new front tires in the ICD business here. Of course, there are always novel algorithms which try also to keep lower number of shocks. But when they keep a shock, these days they are higher with higher energy than what they used to be. For example, 10 years ago, something like 32 or 40 joules for a shock. The batteries, they naturally get better and last longer. Devices at the same time they are smaller. And then there's a very new system, ICD system, which is totally subcutaneous. And it's a device which is implanted here, not here as it typically is. The typical device is then the leads are inserted to the vein here, but these subcutaneous ICDs, they don't use any veins, but the lead is tunneled subcutaneously here, so that the coils are this one here and this one here. So this might be a very useful for certain patients. For example, for patients who have a high risk of infection, so this is much easier to be taken out in the case of infection. And if the anatomy is very difficult for regular ICD, and if there's a person who has certain ion channel diseases, so that which means that he will not need a bradycardia pacing or anti-tachycardia pacing, but he might only need shocks, because this is just a shock box. So it won't give any other type of therapy, but just shocks. So there are certain patients who might benefit of this device, but still with remarkable restrictions. Also, there have been tests with the wearable devices, so that there's a vest which has the electrodes and the device itself is here. But thus far, we don't have any prospective randomized data whether these really are useful. But this might be useful for certain patients, but not for multitude of those. All right, so I think we are at the end of this presentation, and thank you for joining, and please let me know if you have some questions.
Thank you, Dr. Nieminen. I'll now open up the floor for any questions you may have. Just a reminder, if you do have any questions, to please submit them via the Q&A panel on your Q&A window. I do have one question here, Dr. Nieminen. It states, you talked about using stress testing to identify at-risk patients. How do you adjust for the noise from patient movement when looking for specific arrhythmia?
So do you mean the noise in the ECG?
Not quite sure. This was one of the questions on the chat panel that was provided by one of the attendees.
Okay, well, okay, if I understand it correctly, then it's a question about that the ECG might be very noisy during the exercise, which is naturally true, even though particularly the precordial leads, they are typically of nice, quite high quality if the preparation has been done properly. And if we are talking about, for example, exosystos, then it's self-evident that they are, even though the quality would be not optimal. But if we are talking T-wave alternance, then there are algorithms which smooth the ECG and make it possible to calculate alternance also of the ECG. But of course, if there are, if the leads are not properly positioned, then it will be very difficult.
Thank you. Another question, for heart rate response, are there age-adjusted criteria for athletes given the often low resting heart rate and the possibility of LVH? Should we treat the athlete differently?
Okay, that's a very good question. So for athletes and exercise tests, it's true that they have a very high heart rate response because they start at very low level of heart rate and they go to very high. Basically, patients, or at least they are really not patients, typically athletes, we do not use exercise tests to categorize their risk. So if we are thinking about athletes and about their sudden cardiac death risk, typically it's just a regular ECG and echocardiography is taken. And regarding the treatment, basically, no, they should not be treated differently.
Okay, thank you. One other question. Other than LVEF of less than 35%, are there other diagnostic tests to better predict the patients who would benefit from an ICD implant?
Yeah, at the moment, this is the clearly most useful ejection fraction. There has been some studies earlier with some electrophysiological features, for example, whether a patient is vulnerable to get a ventricular fibrillation in an electrophysiological laboratory by ventricular stimulation. And very importantly, there's a study right now ongoing with T-wave alternance. It's in patients who have a ejection post myocardial infarction. They have ejection fraction between 36 and 50%, so they would not be eligible for an ICD. But then they have elevated T-wave alternance and heart rate turbulence, and those patients are receiving ICDs in a study, which will be very important. But at the moment, for ICD, ejection fraction is that's clearly the main point.
Okay, thank you, Doctor. I think there are no further questions. I'd like to thank you all for joining us today, and thank you, Dr. Nieminen, for your presentation. Just a reminder that we have a third webinar session with Dr. Nieminen in the coming weeks, which we will notify you of. And that's all for today. We hope you enjoy the rest of your day.
Okay, thank you very much.
Thank you.